Okay, hi everyone. We're about to get started in a moment. I'm just going to introduce everyone. We have Matt Anderson, President and CEO of Ontario Health, on the far left. We have Steini Brown, Dean of the Dalla Lana School of Public Health at the University of Toronto, in the middle. And on the right, we have Dr. Barbara Yaffe, Associate Chief Medical Officer of Health. I'm now going to turn it over to the presenters for some remarks.
Great, thanks. This is Steini Brown from the Dalla Lana School of Public Health. I'm going to walk through a series of slides, at least the beginning of a series of slides that talk about projections. I'll use these data and projections to talk about where our expectations are for the progress of the disease through the Ontario population, and then I'll turn it over to my colleagues. There should be a set of slides that everyone has and that people can see. If you turn to slide 2, I just want to make a couple quick notes here. The first is that the information that you're going to see here is a product of a number of people working within Public Health Ontario, working within Ontario Health, and researchers across more than 5 Ontario universities. This is led and coordinated through a table here in government, the COVID-19 command table. The information that you're going to see is an effort to try to promote transparency around the progress of the disease, provide people with as up-to-date information as the leadership in the province around COVID-19 is receiving, and also talk about where there's progress, but also where there's more that needs to be done. If you turn now to slide 4, you can actually see, and you'll have seen this slide in the last presentation that we did, you'll see in this slide a timeline of the key public health and healthcare interventions that have come along, starting on January 24th, when COVID-19 was made a reportable disease, and obviously followed very quickly on January 25th with the first reported case of COVID-19, through to the emergency declaration in the middle of March, right through to the most recent initiatives in mid-April around long-term care, the extension of the emergency declaration for another 28 days, and the work deployment for a number of different types of organizations. Turn now actually to talking about the progress of the disease of COVID-19 through the Ontario population. If you're on slide 5 now, I want to start off by talking that we're making it clear that we're really talking about 2 separate disease processes right now. The first is a process of the spread of COVID-19 through the general community. The second is the spread of COVID-19 through long-term care homes and other congregate settings. And I'm going to take some effort to try to distinguish the dynamics of the disease in both of those different settings. So if you remember the earlier discussions, you would have known that our models were predicting a peak of cases in May, a peak of new cases in May. The public health interventions, both large and small, both physical distancing, a very significant sacrifice that people make, the stay-at-home or shelter-at-home instructions, a very big sacrifice, but also smaller things like hand hygiene, keeping surfaces clean, those sorts of issues. That has actually accelerated the peak to now, and so that we're looking for, regardless of the model we use, we're looking at a peak that is right now for the community transmission of COVID-19. Now, peak is important because epidemics follow what's called Farr's law, which means that they essentially have a symmetrical shape. And so as you come up, you peak, and then hopefully cases diminish down the other side of it. And so that's important when we talk about peak, to make it clear that we're now hoping to see a reduction in cases as we go along. Peaks are not a single day. Peaks are not sort of a nice single sort of spike. They can be a little bit bumpy. They can prolong for a period of time, particularly given public health interventions. But we're in that peak period right now. Think back to the earlier presentation where we talked about the expectations of cases under different scenarios. The worst case had been about 300,000 cases. At that point, a couple weeks ago, we've been thinking about 80,000 cases in April as the expected number of cases. We're now looking at a much lower number, hopefully under 20,000 cases in this wave of the pandemic. And so this means that if you think back to sort of our best and worst cases, we're starting in terms of our cases to look more like the best case. However, it's difficult to draw conclusions on mortality right now because of these separate disease processes. Mortality from community-based transmission, we expect is coming down, and we expect that we're going to see a lower number of overall deaths. But the ramp up of cases in long-term care homes, the mortality that follows on that obviously makes it hard to predict a number of actual deaths. And so, if you sort of kind of want to summarize these disease processes, we're at peak in the community, but we are still on that accelerating upswing of the curve right now in long-term care homes. And I want to make it clear that when we talk about long-term care homes, we're really talking about any congregate setting. So that could be long-term care homes, that could be homeless shelters, it could be any place where a lot of people are brought close together for prolonged periods of time. Moving on to slide 6, you can see the epidemic curves here, the number of new cases that we see since the 100th case. People will remember what was discussed by Dr. Donnelly at the last briefing, but you can see it's a logarithmic scale, which means that the space on the y-axis from 100 to 1,000 is as large as the space between 1,000 and 10,000. So the numbers of cases go up quite significantly as you go up that curve. But still, we try to find that point where we see flattening of the curve. And this is this idea that you see flattening the curve, that you're reaching peak, and that you're hopefully starting to come down. And you can see the Ontario curve, most of the provincial curves, the Ontario curve, and even the Canadian curve are now starting to get to that place where the slope of the line changes, and it starts to flatten. There was 606 new cases in the report yesterday based on the IFAS data system. It's important to note that we may be at a place where we're seeing roughly the same number of cases every day as we talked about peak. If you go to slide 7, you can see the tracking of the number of COVID-19 deaths, again the days since the 5th death, and you can see it's again a logarithmic scale on the y-axis, although a much smaller one this time, going from 5 to 50 to 500. Again, you're starting to see a little bit of a curve or a little bit of a shifting of the line here. But remember, deaths will follow cases by, not only the incubation period for the disease, let's say that's 5 to 7 days, but also the time that that disease takes to progress to something very significant, which is an additional period of time. So the death curve will follow the cases curve, but it will not be exactly in line. The other thing, just coming back to these two separate disease processes that it's important to emphasize here, the wave of cases going through long-term care homes right now are affecting, not surprisingly, elderly people. That's where the mortality rate of the disease is the highest. If you go on to slide 8, you can see that epidemic curve again. We've gone back to looking at cases here. What's important to note here is that in any region of the province that we're looking at, we're starting to see that bending of the curve again, which I believe is important as we start to try to sync whether or not we're at peak. In almost every region, you can see that bending quite pronounced, which gives some hope that we're starting to control the community-based spread of this disease. If you go to slide 9, this slide talks about a snapshot of what's happening in long-term care homes. If you're looking at the bottom of slide 9, that red bar that is getting high and now seems to be at 127 long-term care homes for at least 2 days. This is the number of homes with a COVID-19 outbreak. This is important because once the disease enters into a home, it can spread across the home, and so the outbreaks are really critical in terms of understanding what's going to happen in terms of cases and in terms of mortality within the homes. Going from slide 9 to slide 10, you've now got a representation here of COVID-19 cases among residents, COVID-19 cases among staff, and the cumulative deaths among residents. You can see that all these curves are going up, both residents and staff, and making very clear the importance of controlling infection and strong infection prevention and control processes within long-term care homes. And you can also see what would strike as a high number of deaths within long-term care homes. This represents about half of the deaths right now in the province. It's important to kind of note that because this is why it's hard right now to anticipate the overall mortality from the disease. And with that, I'm going to finish off and turn over to Matthew Anderson.
Thank you, Steini. Good afternoon, everyone. Very much appreciate the opportunity to come and address you today. I'm just going to pick up where Dr. Brown left off. For those of you who have the slides, we'll go to slide 12. And this is just to remind everyone that what we did using models that were provided by Dr. Brown and others, we looked at 3 possible outcomes and how they might impact our acute care health system. We looked at a best case, which we modeled off of South Korea. We looked at a middle case, which was really using the data from here in Ontario in around mid-March. And then we used a worst case, which was roughly modeled off of what's going on in Italy. So we had those models, and what we do with those models is we then try to apply a resource impact to them. If you move to slide 13, this is looking at the 3 models and looking at them as they would impact our ICU beds. If you are able to see the chart, the big green line, that is Italy. That's our worst case. And it would say that by mid-May, we would have needed about 5,000 ICU beds dedicated solely for COVID-19. You can see the other 2 lines, the lighter blue and the darker blue, are the medium and best case. And you can see those numbers are very, very different. In the worst case scenario, just under 5,000 ICU beds are needed exclusively for COVID-19. In the medium, it's about 700. And in the best case, it was below 400. If you flip to the next slide, slide 14, we do the same thing, and this is with ward beds, so hospital beds that are not in the ICU. And you can see similar curve here with the in the Italy model, we would need about 10,000 dedicated beds for COVID-19. And then you can see on the blue, which is the medium, you'd compare 10,000 to just under 2,000. And in the best case, you're looking at about 700 beds dedicated solely for COVID-19. So we take those models and we apply them to our resources to try to understand where are we at in terms of preparation and do we have enough capacity in our acute care system to support the rest of our health system and to support society. If you go to slide 15, I'm only going to model the ICU cases because the ward cases would look basically the same. And just to orient you to the slide, and for those of you who maybe aren't able to see it, we've just mapped out those 3 scenarios. The yellow bar that goes up quite high is the Italy. And then you would see the green bar is the medium, and the orange bar is the best, or pardon me, the blue bar is the best case scenario. The pink bar is our actuals. And what you can see in the chart is that what we've been able to do, and when I say we, I mean all of us, everybody listening, everybody who has participated in the public health initiatives, you've made a difference. We are now at a place where our pink bar, the ICUs, the actual use, is trending better than our best case scenario. Now, this started several weeks ago. In fact, interestingly, when we were here last, which would have been April 3rd, if you look at the chart on April 3rd, one of our challenges 2 weeks ago was that the actual number and the 3 other paths were also similar. It was very difficult to know which path would we be on. About middle of about 10 days ago, in around April 7, April 8, you start to see the shift where we actually started to, the models all start to separate as well. The actuals start to separate and have maintained that level. So when we look at this, what this would tell us is that, and along the lines of what you heard from Dr. Brown from a modeling perspective, is that we are tracking well to the best case scenario. And why that means so much to us is for a few reasons. First is the implication is that our public health measures are working. And we need to keep them working. We need to stay focused on our public health measures, and Dr. Yaffe is going to comment on that in just a moment. The second part of this story is that with this additional capacity, we can use it to help in other parts of society or in other systems. Certainly, you've all heard, and Dr. Brown just talked about how we actually have 2 curves going on, one in community and one in long-term care. This allows us to use some of the capacity that is available in our acute care system to support our long-term care system and to try to make sure we can bring all resources to bear possible to help in that situation. The third element that this means is that we can now start to look at how do we bring back the rest of the healthcare system. In particular, we're looking at our elective procedures. When can we start to bring those online, and how would we do that, and in what order? And last week, given the trend that we see here, we in fact started some expert panels looking at that very question as to when can we bring things back online. And then lastly, and most importantly, is this capacity as we think about how to move forward, and as our government considers ways in which to restart our economy and to restart our society, we need to maintain some of this capacity as a buffer should we need to go back into a period, or accidentally go back into a period of community spread, and we need a response from our acute care system. So we've been very successful. You've been very successful in helping us to control the spread and maintain capacity within our acute care system. I'm now going to turn it over to Dr. Yaffe to speak a little bit about our long-term care and where we go from here.
Thank you very much, Mr. Anderson. So I am Dr. Barbara Yaffe. I'm the Associate Chief Medical Officer of Health for Ontario with the Ministry of Health. So if we can turn to slide 17. As you heard, we are having a particular issue in long-term care homes and other congregate settings with outbreaks of COVID-19. So Ontario is now urgently implementing a COVID-19 action plan for protecting long-term care homes and then on to the other congregate settings. And this action plan involves working together between Ontario Health, acute care hospitals, physicians in the community, public health units, Public Health Ontario, and the Ministry of Long-Term Care. We all work together to address this issue. So first of all, it involves aggressive testing of residents, testing of staff. We usually and always, if anybody is symptomatic, even the most minor symptoms, and we know now that COVID-19 can present in many different ways, particularly in elderly people. So if anybody presents with any unusual symptom, they are tested. And as soon as anybody's positive, we routinely make sure that all the people around them, whether they're symptomatic or not, they get tested for COVID-19. In addition, we have been now expanding to do what we're calling more active surveillance, and over the weekend or the last few days, been testing about 21 long-term care facilities, testing every single person in those facilities to see how prevalent is the infection. Are there asymptomatic people or people who have not been picked up as infected who actually have the infection? And this is something we're going to be expanding beyond that. So enhanced testing and leveraging surveillance tools so that we can move proactively against this disease. Managing outbreaks. And as you heard, we have about 127 outbreaks right now reported in long-term care facilities. And being very proactive to support them with infection prevention and control expertise. We're ramping up Public Health Ontario to work with public health and long-term care to go in and do an on-site assessment and determine where are the needs and how can we best address them. Are they basic things like environmental cleaning, bringing in a company to do that? Are they human resource needs? And as we've heard, hospitals and other parts of the health system are helping out, which is unbelievably valuable. Is it personal protective equipment? Do they have enough? Making sure they have enough and making sure they know how to use it properly, how to don and doff it properly, because if you don't do it properly, you can actually infect yourself. Making sure that they're trained and supported. So this is something we're very much focused on now and will continue to focus on, and make sure that the base level of knowledge and expertise and competency in this area is increased so that hopefully this won't happen again with other infections. And redeploying, as I mentioned, staff from hospitals, home and community care to support long-term care workforce and respond to outbreaks, along with very intensive ongoing recruitment initiatives. As you know, the government issued an emergency order directing long-term care employers to ensure that their employees, including registered nurses, registered practical nurses, personal support workers, kitchen and cleaning staff, only work in one long-term care home. Because we know that staff working in multiple locations can, in fact, be a source of infection, unbeknownst to them. And, as I mentioned, enhanced guidance on personal protective equipment. So going to the last slide, slide 18, as the other speakers have said, we have to continue at this point to implement the enhanced public health measures to stop the spread of COVID-19 and flatten the curve. We're probably, as Dr. Brown said, at the peak, but the peak is not just one point in time. The peak can last a bit, and we don't want it to keep going up again. So we have extended the declaration of emergency to at least May 12th to support existing public health measures in place, including restricting social gatherings to 5 people, the closure of all non-essential workplaces, outdoor recreational amenities, public places, bars and restaurants, and those that they can still provide takeout and delivery. We are implementing, as I mentioned, this next phase of the testing strategy right now with long-term care, but we are also going to be going to other congregate settings with vulnerable populations, retirement homes, homeless shelters, group homes, and so on. So everyone needs to continue to stay home as much as possible, maintain physical distancing to ensure that the province continues to stop the spread of COVID-19 and flatten the curve. These actions are making a big difference, and you need to stay the course and stay strong to save lives. Thank you all very much for your work and helping us to keep this terrible infection from spreading more. Thank you very much. I'm going to pass it back to Dr. Brown to take questions.
Okay, just before we take questions, just a reminder, we're going to go till about 1:15. It's going to be one question, one follow-up, and I'll be acting as moderator and operator this time. So our first question comes from Carly Weeks at the Globe and Mail. Please go ahead. Carly, are you on mute? Okay, we're going to move to the next caller. It's Antonella Artuso from the Toronto Sun. Please go ahead. Unfortunately, we're having some technical difficulties, so we're just going to pause for a moment.
In light of the technical difficulties, I'll ask a few questions. People are sitting at home, wanting to go outside, wanting to go to birthday parties, and they can't. Flattening the line and all of these things. When is it, they want to know when is it they can go to their little baseball games or they can go outside and socialize? What do these numbers show?
Barbara, do you want to start with that first? Or?
Sure, thanks. So the question is, when will we be able to go back to normal life? And everyone wants to know the answer to that. Unfortunately, there is no clear answer. And when we do start to lift some of the measures, it will not be a light switch, on-off. It will be very gradual, and we will have to measure the impact of each change as we make it and make sure that we're not seeing more infection as we lift it. Because once we lift it, it will be very hard to go back. At this point, we have to remember that the data we're seeing today reflects the infections that happened over 2 weeks before, probably 3 weeks before, because people get sick, they have to go get tested, The incubation period between exposure and infection is up to 14 days. So we have to give it time, and people have to really stay the course for now.
Okay, and due to the technical difficulties, anyone in the press gallery, they have my email address. Please email me and I'll ask your questions. This question comes from Colin DeMello. Your data shows as of April 18th, 127 homes have an outbreak. Yet publicly recorded data as of April 19th shows there were 114 outbreaks. Why the discrepancy? And similarly, publicly released data shows that 249 deaths in homes as of April 19th, yet your data shows 367 deaths. Another discrepancy. Can you explain why there is a significant discrepancy? Dr. Yaffe?
Yes, we're aware of the discrepancy, and we're working hard with the Ministry of Long-Term Care has their database, and we in Ministry of Health are using the IFIS database, Integrated Public Health Information System, which is data entered by the local public health units. And ideally, we should have the same information. And we are working towards that and bringing the data together. But at this point, the data is not together. And so we look at both databases.
Now flipping over to correctional institutions. As we know, there's I've forgotten which facility was closed down and people in that facility were transferred to another facility. Is there testing being done in correctional facilities, and why did the outbreak get so massive in this one location?
Probably Dr. Yaffe. Sorry.
That's okay. I'm not aware of particular which one, but I do know there have been some. I think it's important to keep in mind that any congregate setting where people are living together in close quarters is a setting where infectious disease is more likely to transmit. And people will remember the cruise ship stories. Now we have long-term care, and we have correctional facilities, and we have other settings, so it's not a surprise. We have been working with the Ministry of Solicitor General and around personal protective equipment recommendations for staff and infection and prevention and control. And I actually have calls scheduled with them later today about that as well. So I think, is there wide testing happening? There is testing certainly around any suspected case. Once it's confirmed, we would be ordering testing of close contacts and staff, including asymptomatic ones. Have we gone to broad testing at this point in that setting? No, not to my knowledge, but I believe that will be coming.
Because there's such a high number of...
Maybe I could...
Okay. Yep, sure.
Maybe I could just follow up on Dr. Yaffe's points as well. So you'll see spread of a disease like this first in the general community. Remember the cases that came, the first cases in Ontario are cases that came from travel. Then you'll see later on the spread start to go through congregate settings as those travel cases infect people within the community, and those people in the community or those people who are traveling then enter into congregate settings. And even with strong policies about limiting visitors and limiting that type of contact, you still see the introduction of the disease through staff and professionals who work in those environments. And so you actually start to see a second wave through all these congregate settings. And so even as you get more comfortable about the spread within the community, you really need to pay very strong attention to these vulnerable environments, whereas Dr. Yaffe said people are living close by, and there's professionals who move from room to room or from place to place and can potentially spread infection without personal protective equipment.
Then was there enough sentinel testing done in these facilities, whether it was correctional institutions or homeless institutions or anything of that nature where these secondary infections will happen?
Well,
okay, let me pan over to you, sorry, Doctor.
Oh.
Perfect, thank you.
I'm not aware of sentinel testing having been done in those settings. I think the sentinel testing has been focused on people who become ill, who go to see their doctor or go to the hospital emergency room, that kind of sentinel testing to look at trends. But again, now we are going to the congregate settings. So that's where we're going to be doing more testing.
Okay, and this question comes from Alison Jones, Canadian Press, and also the president of the Queen's Park Press Gallery. Slide 15 shows confirmed COVID-19 cases, but what about the totals of confirmed and suspected cases? The suspected cases may not have been lab confirmed, but they are still taking up beds. And when we suspected cases into account, are we still in a peak period?
So I'll take that question.
Okay.
Thank you for the question. The suspected cases are not included in this particular chart. We do track those. The main reason they were not included is that they haven't had, the conversion rate from suspected to confirmed has been relatively low, and as they come over, they end up in this chart. As you can see, the confirmed cases have stayed very constant, meaning that the suspected cases has not actually had much of a bearing on the overall utilization in the long run, hence why that number was not included. Even when we do include it, by the way, I would say it still puts us on the medium path or between the medium and the best case scenario. So it does not change the picture dramatically in terms of what we're expecting.
Okay, and then continuation, correct me if I'm wrong, this is Allison again, correct me if I'm wrong, but I didn't hear any new measures announced today for long-term care homes beyond what was in last week's action plan. Does that mean you're confident the current measures will bring the long-term care outbreaks under control?
Dr. Yaffe.
The action plan was announced late last week, and we are in the process of implementing it. We are confident that those measures will, in fact, have a great impact on outbreaks and preventing and controlling infection in this setting, but it doesn't happen overnight. It takes time.
Okay, and this is from Siobhan Morris, News 1010. You talked about it being difficult to predict the number of deaths because of the growth of the COVID-19 in long-term care homes. Can you explain why that makes a difference to death predictions?
Thanks. I'll speak to that. So you see a spread within a community. That is a spread within a community that has the normal age distribution that you'd see in any city, any town, younger people, older people. But the fatality rate, the rate at which people die after infection, is much, much higher in older populations. In fact, the vast majority of death happens among those over 65, and the median age of people who die from COVID-19 right now is about, I think, 85. So it's going to have a much bigger impact on mortality in places where there are significant numbers of older people, and hence what you see is when you see a wave of infection going through long-term care homes, it is unfortunately and tragically going to be followed by a wave of mortality as well.
Okay, and Siobhan also asked, can you talk about the slide on page 8? Is Toronto doing better, worse, or about the same compared to the rest of the province in flattening the curve? And will Torontonians need to do even more to further prevent community spread? And that against page 8 or slide 8.
Great, thanks. Maybe I'll start, and maybe Dr. Yaffe can follow up. So if you look at the rough shape of the curves, and it's really important to watch how the line is actually changing its slope as it goes along. You'll see that the Toronto slope is very similar, although it's higher. It's very similar to the slope, say, in the north. It's very similar to the slope in the east. Maybe a little bit flatter right now than the slope in the central region. And so in sort of simple ways, Toronto doing as well as the other parts of the province, I think you'd say based on the slope or based on that sort of presentation of the data that yes, it is doing as well as other parts of the province. In terms of what more can be done, I'll just note that Toronto is a place with a high concentration of congregate settings, whether it be homeless shelters, whether it be long-term care homes. There are a number of issues there that require great attention. And perhaps I can turn it to Dr. Yaffe for more discussion about the public health interventions.
I would say that, Toronto's doing a very good job. They have more challenges in some ways than other parts of the province because of the concentration of population. Lots of places where it's very difficult to do physical distancing, like homeless shelters, other congregate settings like that. and the transit system. And so they have, some extra challenges that perhaps some in the north don't have, but then the north has other challenges. So I would say overall they're doing about the same as all the rest of the province.
Okay, this question comes from Rob Ferguson, Toronto Star, also the Vice President of the Queen's Park Press Gallery. Is there an estimate on the number of unknown cases in the community? How will testing be approached or expanded once mitigation measures are eased?
Do you want me to, I'll start maybe with a question about how many cases aren't detected. So we don't yet have surveillance level testing in the province that would allow us to look at places where there's no cases, or populations where we see not any cases, and also populations where we see a lot of cases. So we can't answer that question directly right now in Ontario. Looking at the ways that we can aggregate and combine studies from other jurisdictions, the answer depends a little bit on what type of test that you're actually using. So when we look at one type of tests, and I won't go into all the details, it would look like about half of the cases don't develop symptoms. And there's a body of literature from a number of countries right now that says half of those people infected we don't even see. There's another body of literature using other types of tests, though, that will say that that percentage is much higher, that we actually don't see somewhere north of 90% of those people that are infected. And so, to a certain extent, I think people often focus in on what that number is. I think the critical issue here is that we need to be able to get an estimate of that for Ontario that makes sense, so we actually have a good sense of where the disease is in terms of its progression through the population.
I'd be happy to take the second part of that, if that's all right. And of course, I would defer to Dr. Yaffe on testing strategies, but just specifically the concept of what we're trying to do is right now focus our testing on the at-risk populations that you've heard about here. When we feel we've got that well under control and we have done the testing that's required to support those strategies, then that volume of testing can then be moved over to do more broad-based community surveillance the way Dr. Brown has described it.
Okay, Dr. Yaffe, I'm coming to you.
Okay.
Thank you, Dr. Yaffe.
I think the other thing to keep in mind is, we are looking at serology testing, which is testing blood for antibodies. And I know that the Public Health Ontario lab is going through some validations of this testing in terms of what it would actually mean. But one hopes that eventually we'll be able to do what's called seroprevalence studies, where you test a random sample of the population and see, is there evidence that they have been exposed to this infection, regardless of whether they had a history of infection. And that will give us a better idea of how many people really were infected, and how many people of those people, did they have symptoms, did they not have symptoms, did they spread it, what were their risk factors. We'll get a better idea of the whole general population exposure and infection rate.
Thank you. Sorry if I'm seeming distracted here. I'm juggling a few balls here. Next thing is, this is from Laura Stone, Globe and Mail. Question. Ontario has not been doing as much widespread testing, so how much can that impact on what is happening in regards to the community spread? Are we possibly missing some pockets or outbreaks that may be contributing to the institutional spread? And then I have a follow-up.
Maybe I'll start just with a perspective from how we look at the data and how we understand the models. The one thing that we look at is the cases, but because that still is not sort of at a population level, we also look very closely at the harder endpoints like ICU use or death. And as long as we see that sort of pattern of the ICU use and the death sort of tracking in a certain way, then we have comfort that we're probably getting a good handle on what the outbreak looks like in the community. The concern always is that there's a place where there is an outbreak, where you have a super spreader going on or something happening where someone could spread the disease to many, many, many different people. That's something you would be able to find out more, or have maybe a little bit of a leg up on when you get to a broader set of testing. But as long as we see some of the hard endpoints, I don't think we worry about missing something right now. Dr. Yaffe?
Well, I would say, first of all, I agree with Dr. Brown. The hard endpoints of hospitalization and death are pretty valid things to measure. As well, now we are expanding testing, as I mentioned earlier, in congregate settings, starting with long-term care facilities. And we're currently looking at the incoming data from testing every resident and staff person in 21 long-term care homes as a start to see, are we missing infections? And if we are they, we're assuming they're asymptomatic. Did we miss symptoms? So we're looking at that right now.
Thank you. And this question comes from Cynthia Mulligan, City News. The first question is, what do you say to the people that who may be cynical about these numbers and the original ones were so inflated that they are leery about these numbers?
Yeah. So these models have a feedback in them. I think that's sort of the easiest way to put it. When we release a model, when there's numbers that are in those models that look quite frightening, people do change behavior. And if you look out on the city streets, if you look at what's happening, behavior has changed, and that reduces the infection. They feed back on each other. And so I can understand why people say, well, this isn't the same projection as 2 weeks ago. Well, we would hope it wouldn't be the same projection as 2 weeks ago, because you want to see that feedback between here's what would happen, here's what actually is happening now, and then hopefully continuing sort of efforts to both control and suppress the spread of the infection, but also, set the policies that allow one to think about how you resume clinical activity, other clinical activity in hospitals, and other important questions. So there's a feedback, and the numbers are going to change, and if they didn't, then either something's happened terribly wrong with the policy or there's something terribly wrong with the models.
Okay, then
maybe Mr. Anderson wants to add?
I'll just add one point to that. Thank you. Where the models are the models, when we bring it into the resources, it gives us a harder comparison. So while the model may have said something, when we look at what that would have projected to from an ICU capacity and compare it to Italy, those again are hard numbers. So going back to Dr. Brown's point, although there are the case numbers and all those things in the models, when we translate that into how many beds would we need or how many ICU ventilators would we need, those numbers then become a good comparator, which does tell us that the modeling that we were looking at was not unreasonable. Where we are today is, again, thanks to everybody in Ontario for working together to ensure that we got community spread down and are talking about the kinds of numbers we're talking about today. Obviously, with the acknowledgement that we are not done, we have more to do, and certainly right now have more to do in long-term care.
And then when we're looking at, especially when we're looking in the States, we see that the outbreaks are geographically sentenced to certain communities. Yeah. Are we collecting the data with the postal codes in mind, and if not, why not?
Sure. Maybe I'll start with that one. So the data that we collect has postal codes on it, and we're able to do analyses by postal codes or by different sort of groupings of communities. I think there's two important ways, though, to think about communities. One is which is by geography, which is really critical in terms of how you understand how a disease spreads, because it is spread from person to person to person. And so people living in the same community are at higher risk if there's a case than people in a community where there's no case. The other way you want to look at it, though, is in terms of different groups of population. And so if we look at, say, people living in low-income neighborhoods in Ontario, they are now at a higher risk of infection and cases. The initial wave, which was largely driven by travel, that was not the case. But the later waves or later sort of stages of this current wave of the pandemic, people living in low-income neighborhoods are at much higher risk. And if you look into the evidence from the United States, there is a variety of factors about who people are that actually is very strongly associated with their likelihood of getting infection.
Okay, and this is from Lisa Zing from CBC. Dr. Yaffe talked about everyone under 21 everyone in 21 long care term homes. Can you elaborate on the plan to expand this kind of testing, when this will happen, and will this be expanded to all long-term care homes eventually? And what's the timeline there?
wait till the camera comes over my side. Thank you for the question. Actually, this was an item of discussion at the command table this morning, and so I'm waiting to see what the final decision was, but my understanding from the part I was on was that the plan is to expand the testing based on the findings from the first 21. And certainly if a home has even one case, instead of just testing the contacts, which was our previous practice, our normal practice in public health, we will test every single person in that home.
Perfect. And this is a second part, or second question from Lisa. Do these numbers tell us what, in the way that the province could reopen parts of the economy and daily life in some areas could resume while enhancing protections around long-term care homes?
Great. Dr. Yaffe, maybe I can send that to you. You want me to? All right. So, you know, the numbers don't tell the whole story on this. You have to look both at what the numbers say around infection, and as we see the peak of infection come down to a level where, you know, every person spreads it to less than one other person. In the last conference, Dr. Donnelly talked about the R0 number, the number of people that every infected person spreads the disease to. As that number gets down to less than one, so every infected person does not necessarily infect another person, then you can start to talk about the pandemic being under control. But you also have to make sure that there is sufficient public health capacity, that there's sufficient healthcare capacity, and that the parts of the economy that might open up are actually ready to create a safe environment for employees, for students, for customers, or for anyone who might be going to those environments. And that's consistent with the guidelines that you see, whether they be from the World Health Organization or from different states in the US, or even out of the White House. Maybe now I'd turn to Mr. Anderson.
Sure. Thank you, Dr. Brown. And I just would add on that, and going back to some of my earlier comments, that what's so important here is that everybody follow the public health measures, because that has created the capacity now in the system where we can do, as per the question, we want to support those in long-term care and other congregate settings and bring as much care to them as possible. At the same time, we need that capacity that allows us some buffer, if you will, so we can start to look at how do you bring different parts of the economy back online, and we have some safety there to ensure that if something does go a bit awry, we have some capacity to be able to absorb it. So what, again, can't emphasize enough, what you've all done have given us that opportunity where we can start asking these questions.
Maybe I just add one other quick point, or Dr. Yaffe, you'd like to go now?
Yeah, sure, I'll go next.
Good, go ahead.
Once the camera comes back around.
Thank you, Doctor.
Thank you. So in follow-up to the comments so far, which are, I agree with 100%, I just wanted you to be aware that we are having discussions with the other provincial chief medical officers and with Dr. Tam and New at the federal level about this issue, about how to reduce the measures in a consistent, coordinated way. Because we have borders, diseases don't honor those borders, and we are looking at criteria sort of based on what the WHO is looking at, which, you know, have we got the epidemic under control? Does the healthcare system have capacity, public health capacity, workplace prevention? So even the workplaces that are currently considered essential workers, is there more we should be doing to make sure that infection is not being spread there? Are they managing physical distancing properly? Have they looked at other measures like barriers or masks and so on, hand washing, and certainly managing importation risk? We currently don't have any importation because it's not allowed, generally speaking, and anybody who is coming in under special circumstances is quarantined for 14 days. But how do we look at that? Trying to discourage people from traveling within the province even, and making sure that the community is aware of what's happening and what they should be doing and engaged in what they're doing. So that's been working very well so far. Again, thanking everybody, but whatever we do, we have to do it together.
Maybe I'll make one last comment on this question. So I think when we talk about peak, sometimes people hope that means the disease has passed. What peak means is that the public health interventions, both on an individual level like hand hygiene or at a societal level like the physical distancing, those have suppressed the spread of the disease. It doesn't mean that the disease has left the population. It doesn't mean that the disease is sort of passed over, so to speak. It just means that the current set of interventions are pushing down the rate of infection, which means that we start to see fewer and fewer cases as they go along. And so it's important just to keep that in mind, that this is peak given the set of public health interventions that we see in the community now, not peak independent or separate from those interventions.
Okay, and this is the last question, and I thank everyone for their patience online. Also, just a reminder, if you do have a question you were missed out, the Premier will be available later on this afternoon. So this question comes from Antonella Artuso from the Toronto Sun. Could you given everything, could you ramp down social distancing measures and then ramp them up again for a second wave? Are there other measures than just a full shutdown to deal with this second wave? And then a further note is, with SARS, MERS, and all the other, there is a second wave. What does your modeling number show when and where and how big the second wave will be?
Do you want to start, Dr.?
I'll start and then turn it over to Dr. Brown. I think that we have to keep in mind that if we start to ramp down a measure, for example, social distancing or physical distancing, we have to do it slowly and carefully and measure the impact before we go any further. And I think it will be difficult to go back up. I think people are, they're staying the course now, but once you kind of let people get out and it'll be nice in the summer, hopefully things will be better by then. But I don't want to start letting people completely let go of social distancing, and then if we have, as Dr. Brown said, the virus is still there. So we don't want to have a second wave. We would prefer to avoid having a second wave by taking things slowly and carefully. So I'll turn it back to Dr. Brown.
Thanks, Dr. Yaffe. So I think it's important to keep in mind, right, that this is not a sort of dimmer switch that you can kind of turn it down or up and have an immediate response in terms of how bright the light is. When you reduce the social distancing, you will increase the spread of the disease, and that will show up in places like hospitals or intensive care units a week, 2 weeks, 3 weeks down the road. And often by the time that hard endpoint shows up, it's actually too late to kind of turn down the dial again. I think sometimes, when we think about the models and what they tell us, the models are partly about how we control the spread of infection, and they're partly about how we control the mortality of the disease. They're also about how we maintain the sustainability of our health system. And that's where, the exponential growth of a disease can very, very quickly overwhelm a system. And that's, tragically why when we talk about a worst case, we talk about some of the situations that have happened in Europe, like Italy or elsewhere, where that sort of dramatic exponential growth very quickly overwhelmed a health system with, just incredibly tragic consequences, both for people who need to be cared by the system, but also the people working within the system.
Okay, thanks everyone. Unfortunately, that's all the time we have. I appreciate everybody's patience. Thanks again.